Thank you for being here today. I'm Sapna, your host for today's webinar. I request Dr. Samir Job, sir, to start this session. Thank you, and over to you, sir.
Thank you, Sapna. So, welcome friends again in our Saturday webinar. This will be the last mock theory exam discussion session. So far, we have discussed around 20 questions and model answers by our colleagues who have just passed DRNB exam in last 2-3 years. So, this will be our last session on question answers. I know unfortunately lot many students did not get the question paper. I had emailed the question paper to your guides and teachers 2 days back, that is on 13th and 14th of November, but you may not have got the question paper. So what we would do today, my two young colleagues, Dr. Avrojit from Kolkata, welcome Avrojit to our webinar, and
Thank you, sir.
my colleague Dr. Supriya, she will be discussing next 5 questions. These two will just read the questions loud first, the whole question paper, and then we'll start discussing the answers so that you know at least the questions what they're discussing about. Okay. So Avrojit, let's start with your first 5 questions. Read the questions first. Start discussing.
Okay. A very good afternoon to Samir sir and all my colleagues. So I'll just go through the question paper first. The first question is discuss the principles of thromboelastography. Discuss 3 clinical case scenarios with diagrams in which TEG guides the transfusion decision. Am I audible?
Yes, go ahead.
The second question is primary and secondary surveys in a case of polytrauma. Third question is describe the physiological thermoregulation. Enumerate any 4 common non-infectious causes of rectal temperature greater than 38 degrees Celsius in an ICU patient. And the last part of the third question is write a note on neuroleptic malignant syndrome. The fourth question is describe the benefits and harms of Peep in mechanical ventilation. Describe 3 common methods of Peep optimization in ARDS ventilation. The fifth question is discuss the Supreme Court verdicts in the field of end of life care in India.
Okay. So Avrojit will now discuss the model answers one by one. So we have tried to make the perfect answers for you, and you should get an idea how to write the answer. Again, I repeat, the basic ideology of writing a theory question is in 180 minutes you have to finish 10 questions, means for each question you will get around 16 to 17 minutes, and you have to finish the answer in that much period. Among these 5 questions, the most difficult will be for some students, TEG might be the most difficult question. For some students, Supreme Court verdicts might be the most difficult question. But other 3 questions are relatively straightforward. So what I would suggest that you spend a little more time on other 3 questions while you write the answer and score around 7 to 8 marks out of 10 in those questions. And the difficult one, for example, TEG, that is thromboelastography or ROTEM, and Supreme Court verdicts are relatively difficult one because we don't study that much in detail about this. This is my version. Somebody might find it very easy, but by and large, I'm talking about average number of students. So spend less time while you write the exam on these 2 questions because you will write something which is not required, non-relevant, and will not be scored marks. So keep 10 to 11 minutes for these 2 questions to write the answer and spend around 21 minutes for the rest 3 questions on PEEP, temperature regulation, and other questions. Okay. So Avrojit, start.
Yes, sir. The first question is discuss the principles of thromboelastography with diagram. Discuss 3 clinical scenarios with diagram where TEG guides the transfusion decision. So what is TEG? TEG is a viscoelastic hemostatic assay that measures the global viscoelastic properties of whole blood clot formation under low shear stress. What does TEG look at? It looks at the interaction of platelets with coagulation cascade, which includes the aggregation, clot strengthening, fibrin cross-linking, and fibrinolysis. Physical properties of the clot in whole is measured. It's a mechanical electrical transducer. The elasticity and strength of the developing clot is then converted into electrical signals, giving a graphical depiction. Kaolin and kaolin plus tissue factor is used as activators. So this is the classical description of a TEG. TEG, there is a R fraction, there is the K, there is the alpha angle, then it reaches the maximum amplitude, that is when the clot is finally formed, and then the fibrinolysis start. So A30 or lysis 30 is the point where after 30 minutes after maximum amplitude, the fibrinolysis has processed, and that gives us an idea of the fibrinolytic process. So R value, it's called the reaction time, is dependent on the clotting factors. Normal is 4 to 8 minutes. K is dependent on the kinetics. It gives us an idea of the level of clot strength, and dependent on fibrinogen. Alpha angle is the slope of line between R and K. The normal value is 47 to 74 degree. It assesses the rate of clot formation in the propagation phase and dependent on the fibrinogen. MA gives the idea of the overall stability of the clot. That's the maximum amplitude. The normal is 55 to 73 millimeter. Lysis 30 is the percentage decrease of maximum amplitude at 30 minutes and gives an idea of the fibrinolysis. So how does TEG guide us? If the R time is increased, we'll give FFP. If there's a decrease in alpha angle, we'll give cryoprecipitate. If there's a decrease in maximum amplitude, we'll give platelets. And if we are suspecting fibrinolysis, we'll use a tranexamic acid or aminocaproic acid. So let's just go into the case scenarios, which will help us to understand this better. For example, TEG has been used for a long time to guide product transfusion. There has been studies by, I've quoted some, by Hagamo et al., Sankankutti et al., Gonzalez et al., Daluz et al. Was a big study. It showed that TEG-guided product infusion decreases the use of products and gives us better results. What are the common problems encountered during massive transfusion? We get hyperfibrinolysis, hypercoagulability, qualitative platelet dysfunction, or dilutional coagulopathy. So if there is secondary fibrinolysis, as we have already discussed, the R and K will be decreased, MA and angle for low platelet function, the MA will be decreased, we'll give platelets. For hypercoagulation, which can occur later in the process, where the R and K is decreased and the MA or alpha angle is increased, we'll consider anticoagulants. If clotting factors are low, where R will be increased, we'll give FFP. TEG has also been used. TEG has also been used in liver transplant. We have during liver transplant, bleeding is commonly encountered in the prehepatic, anhepatic, and neohepatic phases. Bleeding may be due to primary fibrinogen deficit of the hepatic disease, hyperfibrinolysis of the donor liver, or platelet dysfunction or low platelets. After we have ruled out fibrinogen deficit and fibrinolysis. The first evidence of using TEG in liver transplant was in 1966. After that, there have been multiple studies which has advocated the use of TEG. The importance are by Leon et al. And Mellet et al. So I've already discussed the TEG findings in hyperfibrinolysis and platelet dysfunction. If we have a low fibrinogen level, the K will be increased and the alpha angle will be much decreased or flat. In this case, we'll give a cryoprecipitate. There have been multiple studies. In fact, there has been a TEG-based transfusion strategy in PPH. It has been proposed by Solomon C. et al. The common problems of coagulation in PPH are secondary hyperfibrinolysis and hypofibrinogenemia. There has been evidence in favor of using TEG in obstetric hemorrhage, which leads to less use of blood products. However, there has been no difference in the final outcome. So in this case, again, we will go to the TEG findings of hyperfibrinolysis and hypofibrinogenemia. This is the TEG of hyperfibrinogenemia, and this is the TEG of hypofibrinolysis. The next question is primary and secondary survey in polytrauma. The ATLS 10th guideline gives a extensive primary and secondary survey, our challenge will be to condense in such a manner that we can, as sir said, to reproduce it within 10 to 11 minutes. So what is primary survey? The primary survey is the initial step in evaluating a polytrauma patient. It's focusing on identifying and stabilizing life-threatening conditions. It will follow the ABCDE approach, which stands for airway, breathing, circulation, disability, and exposure and environmental control. The step should be completed within minutes of the patient's arrival to address any immediately life-threatening issues, and we will try to address those life-threatening issues as part of the primary survey. So we'll rather use a flowchart for primary survey. We have divided primary survey according to airway, breathing, circulation, disability, and environment and exposure. In airway, we'll see if the patient can vocalize. There's an obstruction from blood product or vomiters. There are foreign objects. We'll look for facial trauma. In the management, we'll use suctioning. We'll use airway adjuncts like an OPA or advanced airway management like intubation. If video laryngoscope is available, we'll try to use a video laryngoscope. Cervical spine protection must be done. And if a cervical spine injury is suspected, we'll immobilize the cervical spine. We'll use a collar and we'll try to use a manual stabilization during intubation if it is required. For breathing, we will inspect, palpate, and auscultate. The primary problems might be pneumothorax, hemothorax, and flail chest. For pneumothorax, we'll go for an urgent needle decompression or chest tube insertion. For an open pneumothorax, we'll seal with a dressing. For flail chest, patient might require a positive pressure ventilation. Focus has been used as an adjunct in physical examination in unstable patients as part of the primary survey itself. In circulation with hemorrhage control, we'll look at the vital signs, we'll assess for external bleeding and evaluate the signs of hypoperfusion. We'll look at pulse, capillary refill time. In case of external bleeding, we'll apply direct pressure, we'll ensure early vascular access, we'll give balanced blood product transfusion, and limit the use of crystalloids to avoid coagulopathy and metabolic derangement. Neurological examination will if there is neurological compromise, imaging and interventions such as hypovascular therapy might be required. We'll look for early neurosurgical consultations in patients with evidence of head injury. We'll get a head-to-toe exposure to look for any signs of trauma. In environmental control, we'll try to control the hypothermia, which can exacerbate shock and coagulopathy. Active warming measures like warm blanket and warmed IV fluids need to be used. In the resuscitation, we'll use fluid resuscitation, limit the amount of crystalloid infusion, and look at a permissive hypotension for bleeding patients maintaining systolic blood pressure around 80 to 90 millimeter of mercury. The secondary survey will do a comprehensive head-to-toe examination to identify all injuries that are not life-threatening but still require treatment. We'll take a smart look at the history. There's the ample mnemonic, A for allergies, M for medications currently used, P for past illness and pregnancy, L for last meal, E for events and environment related to the injury. Again, in the secondary survey, in the head and face, we'll look for laceration, contusions, skull fractures, signs of basilar skull fracture. We'll look for ocular trauma and look at optic acuity. And we'll pay special attention if there are injuries to the mandible and maxilla. In the neck, we'll look at the nexus and Canadian C-spine rule. If it is low, a patient might not require radiology. Otherwise, we'll look for radiographic series or CT. We'll look for isolated paralysis of an upper extremity, which can indication of a cervical injury. Carotid auscultation and palpation in case of penetrating injury. We'll need to, if there's a penetrating injury, we'll have to consider CT angiography or a duplex USD. If there is platysma breach, there can be chances of injury to deeper organs, so we'll take a surgical evaluation. Again, in chest, other than pneumothorax and hemothorax, we have to look for cardiac tamponade and we have to assess the ribcage, sternum, and clavicle. Imaging will encompass X-ray, CT scan, and we'll use the ultrasound. The abdominal X-ray will look for abdominal examination and pelvic examination. Will look for bruising, tenderness, focus, and definitely a perineal examination. We'll try to apply a pelvic binder in suspect of pelvic injury to minimize the blood loss. We'll have to consider pregnancy test in women of childbearing age and assessment with sonography. Coming to extremities and spine, extremity examination will look for fractures, dislocation, vascular injuries, pulses, capillary refill time, and sensory function. Fracture needs to be managed, and also according to level of contamination, antibiotics need to be administered. Spine examination, full assessment of the cervical, thoracic, and lumbar spine for deformity, tenderness, or neurological deficit. Will go for imaging in case of high energy trauma mechanism or patients with orbital metal status. Also, along with the secondary survey, we'll conduct some lab tests like blood gases, lactate levels, a complete blood count, information perfusion, oxygenation, overall physiological status. Some special procedures like angiography and endoscopy may be required. We'll go on frequently re-evaluating the process of secondary survey. The third question is describe physiological thermoregulation. Enumerate any 4 common non-infective causes of rectal temperature greater than 30 degrees Celsius in ICU patient. Write a note on epileptic malignant syndrome. So I'll suggest using a flowchart when you're describing physiological thermoregulation. There are 2 kinds of sensors, the peripheral sensors and the central sensor. Peripheral sensor are the nociceptive neurons with temperature activated transient receptor potential channels, or TTRP. They transmitted to a lateral spinothalamic tract. Central sensors, they sense the core temperature, and they are the temperature sensitive neurons in the preoptic area of the hypothalamus. They then transmit it to the preoptic area of the hypothalamus, which is the integrator of the central and the peripheral sensors, and then the integrator gives effect to the effectors, which can be skin vasodilatation or vasoconstriction, non-shivering thermogenesis, shivering, hyperventilation to increase evaporative heat loss, sweating, behavioral changes, and the least important is the piloerection. Commonest cause of non-infectious fever. The commonest cause is obviously transfusion reaction. It can be drug-related, chemotherapeutic drugs, antibiotics, anti-epileptics, neoleptic malignant syndrome, serotonin syndrome. Inflammatory conditions like pancreatitis, vasculitis, SLE, or central clause like hemorrhage, SOL, etc. Hydrocephalus. Neoleptic malignant syndrome has been defined as to be characterized by fever, muscular rigidity, and dysautonomia after exposure to dopamine blocking agents, especially antipsychotic drugs. So the diagnostic criteria of NMS has the 3 has to be there, including exposure to a dopamine blocking drug, severe muscular rigidity, and fever, and at least 2 of the following: diaphoresis, dysphagia, tremor, incontinence, altered level of consciousness, mutism, tachycardia, elevated or labile blood pressure, leukocytosis, or elevated serum creatine kinase levels. We will take any 2 of this, and however, all 3 of the primary diagnostic criteria has to be present. So what do we do to manage this kind of a case in a critical care unit? First, we discontinue the implicated agent. In airway and respiration, there might be rigidity of the upper and lower respiratory muscles and diaphragm, with stupor, altered mental status, siluria, all of which can endanger the airway. We will use mucolytics, glycopyrrolate, definitive airway, or ventilatory support. High fever can be present. We'll use will normalize core temperature, cooling systems like surface cooling, ice packs, cooled saline, mist and fan, paracetamol. The definitive agent of NMS, that is dantrolene, also acts in high fever. There will be fluid disbalance due to dehydration and rhabdomyolysis. We will give profuse IV fluids. We will target a urine output of 200 to 300 ml per hour. There might be rhabdomyolysis with elevated CPK. We'll give fluids. We'll dialyze if there is azotemia, volume overload from treatment, severe hyperkalemia, hypocalcemia, and we'll give dantrolene to prevent rigidity and to lower CPK. There might be labile blood pressure leading to secondary myocardial ischemia. We'll use clonidine and clevidipine for that. Dysregulitemias like hypocalcemia, hypomagnesemia, hypo and hypernatremia, hyperkalemia, and metabolic acidosis are common. We'll correct that. Liver enzymes only transiently raised. We don't need to treat that. Agitation might be there. We'll treat it with lorazepam, dexmedetomidine, or ketamine. Muscle rigidity, we can use muscle relaxants like lorazepam, dantrolene, and dopamine agonists like bromocriptine and amantadine. In life-threatening cases, electroconvulsive therapy has been advocated. And along with that, we'll take care of other supportive and preventive issues like we'll give a proton pump inhibitor, DVT prophylaxis, nutrition, and skin and eye care. So we'll go to question number 4, the benefits and harms of PEEP in mechanical ventilation and the common methods of PEEP optimization in ARDS ventilation. So what are the benefits of PEEP? I've tried to underline the important benefits: increased alveolar recruitment, which leads to increased arterial oxygenation, increased mean airway pressure, which leads to decreased hypoxic vasoconstriction, reduction and prevention of atelectasis, redistribution of alveolar edema to interstitial space, recruitment, reduce interpulmonary shunt, and increased mixed venous oxygenation and improved tissue perfusion. There's a study I've quoted along with that. What are the harms of PEEP? PEEP, especially high PEEP, can lead to multiple harms. The pulmonary harms are barotrauma or over distension of alveoli, converting them into physiological dead space. Extrapulmonary problems that we encounter with higher PEEP are decreased venous return, RV dysfunction, raised intracranial pressure, renal dysfunction, decreased mixed venous oxygenation, decreased spastic perfusion and oxygenation. So, what are the methods? First, we'll look at the PV loop. So, in the PV loop, there is a lower inflection point, which is the critical opening pressure. PEEP above lower inflection point will increase the lung compliance by recruitment. During inspiration, alveoli with PEEP above LIP will require a lower pressure than distending up collapsed alveoli. Upper inflection point is the point at which the compliance decreases. So, according to the study by Amato et al., we start with setting a PEEP at 2 centimeter of water more than the LIP. This is the PV loop. We'll need to draw it. You need to point the lower inflection point and the upper inflection point. So, what are the drawbacks of the PV method? We need a deep sedation or paralysis to required to get a correct PV loop. We need a flow of at least 10 liters per minute, subject to variation in identification of LIP and UIP, and we need a esophageal manometry to require to calculate the actual lung compliance. In case of edematous lung, it can be a confounder to using the PV loop method. So we can use an esophageal manometry to monitor the transpulmonary and driving pressure, which can give us an idea of the PEEP titration. The F1, F2, and Pintado trials have suggested positive outcomes during esophageal manometry. However, the final outcome remains the same, and it's those are non-inferiority studies. The goal to have an inspiratory pressure of less than 15 centimeter of water. Obviously, we'll use the driving pressure method. The driving pressure is tidal volume by lung compliance. So driving pressure is also P flat minus P. P flat minus P gives us VT by CRS. So lung compliance is VT by P flat minus P, where PEEP and VT are independent variables which can be altered to change the plateau pressure. So if with increasing PEEP and with a fixed tidal volume, the driving pressure increases, it decreases, it indicates a good compliance. If with increasing PEEP, driving pressure increases, it indicates poor compliance. We use a cutoff of driving pressure set to around less than 15 centimeter of water. The initial PEEP can be set using the PEEP FI2 chart of ARDSnet or using the Gattinoni method of PEEP. Amato et al. Has demonstrated in the meta-analysis better outcomes with driving pressure as a predictor for PEEP. We can also use the USG guided PEEP optimization method. We'll first identify the most dependent part of the lung. We'll categorize it as normal, which is the normal lung, B1, where there are less than 50% B lines, B2, which is greater than 50% B lines, and C is consolidation. If any region is inhomogeneous, then then the worst possible finding is then that region is categorized as that finding. For example, if there's B lines as well as consolidation, we will take it as C. We'll first identify the PV loop to start with our starting PEEP. We'll increment it at the increments of 2 centimeter of water, and we will stop the incrementing when the category C changes to B1 or B2. If there is no change in category, then maximally increase up to 22 centimeter of water, and that is set as the optimal PEEP. There have been 4 major studies: Rode et al., Tang et al., Ranwan et al., and Salem et al., who have found this method to be non-inferior to the ARDSnet method of titration. Only Salem et al. Found a mortality benefit. However, it has the benefits of being cheap, it has an easy learning curve, and avoids repeated ABG and ionizing radiation. The next question is the
just 1 second. If one correction is, if specifically only 3 methods of PEEP titration are asked, just write the best 3 methods you are aware of. Unnecessary writing 4th and 5th method will not give you more marks, because specifically only three methods are asked. So any three methods you can write.
Okay,
So
sir.
don't waste your time in writing unnecessary information which is not going to add to your marks, right?
Okay, sir.
Okay.
Okay. The fifth question is the Supreme Court verdict. So I will advocate using a flowchart to show how the Supreme Court verdicts have progressed in India. First, there are two basic concepts in understanding this. One is the end of life care and the advance directives. End of life care is designed to manage pain, uh, alleviate symptoms, and ensure that the patient's remaining time is meaningful and comfortable. It will include support for the family and is focused on quality of life rather than curative measures. Advance directive is a document where an individual records their medical treatment preferences in case they become incapable of making these decisions themselves. It can include specific instruction about the type of treatment and what they would want or not want. For example, they might not want resuscitation, intubation, artificial feeding, etc. So initially in India, euthanasia was prohibited. That included active as well as passive euthanasia. Passive euthanasia meant that we could not withhold or withdraw life support. The Indian Penal Code criminalized actions leading to intentional death, including those that might occur as part of assisted dying. That is, even passive euthanasia was criminalized in IPC. In 2006, the Law Commission of India published its 196 report separating foregoing of life-sustaining treatment from euthanasia or abetting suicide. That is the first time foregoing of life-sustaining treatment, that is withholding or withdrawing life-sustaining treatment, was separated from abatement of suicide. One landmark case was the Aruna Schonbach case versus the Union of India, in which the Supreme Court for the first time recognized passive euthanasia under strict guidelines, permitting the withdrawal of life-supporting measures in certain cases. The biggest change came in 2018. The verdict passed in the case against Common Cause versus the Union of India. A five-judge bench of the Supreme Court recognized the constitutional right to die with dignity and under a constitutional change of the Article 21 and upheld the validity of advance directives. So we'll just go through it in short. The first part, there are five key components of the 2018 judgment. The first part was recognition of the right to die with dignity. There's a right to life under Article 21 of the Indian Constitution. It was changed. The second part was living will or advance directives. It permitted individuals to draft advance directives or living wills, allowed to specify their treatment preferences if they became incapable of making decisions due to terminal illness or irreversible condition. There was a guideline for implementation. It had to be done and attested by two witnesses and a judicial magistrate of first class. And there was safeguard against misuse because a judicial magistrate was involved. The most important part is there was a provision for passive euthanasia, that is withholding or withdrawing life support for incapacitated individuals who did not have advance directives. A person has got incapacitated, cannot, is on ventilator maybe, and cannot give it advance directives. In that case, there has been a provision which has been made in this 2018 guideline. What the 2018 guideline says is it will have to be done after constituting two boards: the primary medical board, which will need to have the head of the treating department or at least three experts from the fields of general medicine, cardiology, neurology, nephrology, psychiatry, or oncology with experience in critical care and an overall experience of over 20 years, and a second board appointed by district collector, which will encompass the district medical officer as the chairman and three expert doctors who are not part of the primary medical board. In 2019, the Indian Society for Critical Care Medicine filed a petition against this, saying that it was too cumbersome. So there, in 2023, again, we had some modifications to the guidelines of the 2018. The initial criteria for 20 years have been reduced to 5 years. The primary and secondary board have to take their decision within a 48-hour framework. The chief district medical officer can be excluded and he can nominate someone in his place. The members on both boards have been reduced to 3 people. The primary and secondary board are now required to communicate the decision to withdraw treatment to the judicial magistrate along with consent of the close relative or guardian. So this is the outline of how it works. In case the primary and the secondary board are not in concurrence, in that case, the aggrieved family or the treating team can approach the High Court. And if both the primary and secondary team has concurred, the hospital shall record and intimate the judicial magistrate, and the treating team shall implement the decision to withdraw or withhold life support treatment. Thank you.
Thank you, Avrojit, for discussing these 5 questions. Now we'll move on to next 5 questions, which Dr. Supriya will discuss the next 5 questions. Over to you, Supriya. First, read the questions slowly, and then we'll discuss the answers. Okay.
So the first question is discuss the mechanism of action of non-adrenergic inotropes for 4 marks. Enumerate indications of these in the ICU for 6 marks. Second question is goal classification of severity in COPD and how do you manage dynamic hyperinflation in a mechanically ventilated patient. Question 3 is review in short literature about renal replacement therapy in ICU. And fourth question is describe methods of indirect calorimetry. Write a short note on immunonutrition. Fifth question is explain the biostatistical terminologies with examples and diagrams. First is number needed to treat for 4 marks, Kaplan-Meier curve for cumulative survival possibilities for 3 marks, and consort flowchart for 3 marks.
Okay. We'll start the answers now.
So the first question is discuss the mechanism of action of non-adrenergic inotropes for 4 marks. So I've made to the point answers here, and assuming that you would remember at least 70 to 80% of the points discussed here, we can go ahead. So non-adrenergic inotropes are agents that increase the force of myocardial contraction without directly stimulating the adrenergic or sympathetic receptors. First is the phosphodiesterase inhibitors like milrinone. We put an example here. Phosphodiesterase 3 inhibitors prevent the breakdown of cyclic adenosine monophosphate, which inhibits phosphodiesterase enzyme in myocardial and vascular smooth muscle cells. Increased cyclic AMP levels enhance the calcium entry into the myocardial cells, which leads to positive inotropic effect. It also causes vasodilation, reducing the afterload and lowers the myocardial oxygen demand. Second is calcium sensitizers, example levosimendan, binds to the cardiac troponin C, enhances the sensitivity of contractile proteins to calcium without increasing the intracellular calcium levels, promotes the positive inotropic response without an increase in the myocardial oxygen demand. It also opens the ATP-sensitive potassium channels in vascular smooth muscle, leading to vasodilation and improves systemic and coronary circulation, reduces the cardiac workload. If you notice, I have specifically not written full sentences here. You are supposed to write bullet points and try to incorporate the maximum information in the minimum space given. Third is cardiac glycoside or digoxin. It inhibits the sodium-potassium ATPase pump on the cardiac cells and indirectly increases cellular calcium, augments the contractility, mild positive inotropic effect, but it is preferred for rate control in AF with concurrent heart failure only. The fourth myosin activator is an optional agent, which we can mention or not. It is omecamtiv mecarbil, enhances the myosin actin cross-switch cycle efficiency, increasing the myosin activity, increases the duration of active phase of myosin, leads to stronger and prolonged cardiac contractions, but it needs further studies as different studies have varied oral and IV dose regimens. The next sub-question is the next inotropes in ICU for 6 marks. Here we'll proceed with the most important points to the least important. So the first is acute decompensated heart failure and cardiogenic shock, where the non-adrenergic inotropes increase the cardiac output, especially in right-sided heart failure or pulmonary hypertension. Levosimendan is reserved for patients with cardiogenic shock, not responding to adrenergic agents or those with IHD due to its minimal impact on myocardial oxygen consumption. Here, if you can remember, we can mention the SURVIVE trial, which says that levosimendan improves short-term hemodynamics compared to dobutamine, which did not impact the 180-day survival significantly. And the OPTIMED CHF trial, which said that milrinone can improve symptoms in patients with decompensated heart failure, although it may increase the risk of arrhythmias. Again, this is optional. You cannot remember all the studies. The second indication here is postoperative low cardiac output syndrome. So improve cardiac output, by avoiding excessive adrenergic stimulation in patients with significant myocardial dysfunction or stunning post-op surgery. Levosomendan is used in high-risk patients with poor LV function preoperatively, providing sustained hemodynamic support for up to 48 hours post-administration. Here we have two studies which you can mention if you remember. First is the Cheetah study, which shows that levosomendan reduced the incidence of post-op low cardiac output syndrome in patients with low preoperative ejection fraction. And there is a levo-CTS trial which compared milrinone to levosomendan and showed that both the drugs can be effective for LCOS management with increased incidence of hypotension with milrinone. Third is weaning from cardiopulmonary bypass or mechanical ventilation. Provide cardiac support in cases of myocardial stunning post-op while reducing the catecholamine exposure. Here, evidence is the LICORN trial indicated to improve cardiac function with levosomendan during weaning from cardiopulmonary bypass in patients with impaired ventricular function. Fourth is the right heart failure and pulmonary hypertension, which says that milrinone is effective in RV failure in acute cor pulmonale, RV infarction, or severe pulmonary hypertension. Fifth is the heart failure with reduced ejection fraction, which in chronic heart failure with reduced ejection fraction. To standard therapies, levosomendan improves the contractility without increasing the risk for arrhythmias. Sixth indication, bridge to transplant or mechanical circulatory support in patients awaiting heart transplant or awaiting placement of ventricular assist devices. Milrinone can be used to optimize hemodynamics, reduce afterload, provide symptomatic relief, and improving organ perfusion.
Again, my suggestion here is if it's specifically asked three indications of using these agents in the ICU, I think it's worthwhile to just write the three best indications of non-adrenergic inotropic agents, which Supriya just discussed first three, and stop, because these additional writing will not fetch you marks, because if the specific question is asked three indications, then the answers should be written only for that. If the question was write common indications of using these agents in ICU, then your list may go to 7, 8, 9 indications, and which will fetch you more marks. So here the question was designed to get three indications and write little detail about those three indications where you would like to use phosphodiesterase inhibitor or calcium channel sensitizer, which are available in India at present, right? So the 6th, 7th, 8th and 9th indications may not fetch you mark specifically for this question, but it's good for discussion. Okay.
Septic shock with myocardial depression and congenital heart disease in pediatrics. Whole classification of severity of COPD, which is for 4 marks, and how do you manage dynamic hyperinflation in a mechanically ventilated patient for 6 marks. So the goal classification. So the goal classification, we mentioned the four classification. First is mild with the FEV1 of more than 80% of predicted with mild airflow limitation. Goal 2 is moderate with less than 50 to 80% of predicted FEV1. Moderate airflow limitation often associated with exertional breathlessness. Goal 3 or severe classification is FEV1 30 to 50% of predicted with severe airflow limitation, increased breathlessness, reduced exercise capacity, and recurrent exacerbations. And goal 4, which is very severe, FEV1 less than 30 of predicted with very severe airflow limitation, impaired quality of life with potential for life-threatening exacerbations. Here, I would also like to mention the 2024 update in the gold classification. There was a 2023 and now a 2024 update. With relation to critical care, the only important point here is initially the ABCD classification has been changed to ABE, where group A is low symptoms, low exacerbation risk. Group B is high symptoms, low exacerbation risk. And group E is high exacerbation risk regardless of symptom level. And if we are short of time in the exams, drawing this diagram is good enough. It's given in the Tata Bright book also. The next question is managing dynamic hyperinflation in mechanically ventilated patients. This is for 6 marks. So first is optimizing ventilator strategies, mode, any mode, but volume control is preferred because it is the most studied. Smaller tidal volumes start with 6 to 8 ml per kg idle body weight. Decreased respiratory rate start with 10 to 12 breaths per minute. Higher inspiratory flow, 60 liters per minute with constant flow pattern or 80 to 90 liters per minute with a decelerating flow pattern. Increase expiratory time, targeting an I ratio of 1 is to 2 to 1 is to 4, with short inspiratory time, allowing complete exhalation before next breath. Titrate FiO2 to maintain saturation of more than 94% in asthma and 88 to 92% in COPD patients. Peep start with 0 when the patient is sedated and paralyzed and later increase to 5 centimeter. Titrate to 80% of the intrinsic PEEP in COPD patients. Trigger sensitivity 2 liters per minute and set peak pressure alarm above the patient's peak pressures to avoid hypoventilation because of the high resistance. Permissive hypercapnia with a target pH of more than 7.2 and PCO2 levels acceptable up to 60 to 70 millimeters of mercury to prevent dynamic hyperinflation by avoiding high minute ventilation requirements. Then we move on to sedation and paralysis. So, improved patient comfort, decrease oxygen consumption and air trapping, prevent better patient ventilator synchrony, opioid fentanyl 1 to 2 micrograms per kg per hour, neuromuscular blockade only if patient is not adequately ventilated despite deep sedation, restrict for 24 hours, and preferred drug is cisatracurium 1 to 2 micrograms per kg per minute. We also include single sentences about the bronchodilator therapy.
Supriya, just 1 second. Regarding sedation, especially in severe airflow limitation and bronchoconstriction, fentanyl may not be a good choice because, as you know, it's an opiate drug, may lead to histamine release and bronchoconstriction. So, the best choice for at least writing in or benzodiazepine or dexmedetomidine in some time, but you mean in your practice also, if it is severe bronchospasm leading to peak airway pressure leading to 70 and 80 centimeters of water, it's better to avoid any opiate because you never know which is the cause of bronchoconstriction, whether it is opiate induced or it's a natural disease of the patient, right?
So monitoring auto PEEP levels, bladder pressures, oxygenation, and hemodynamics. Individualized ventilation strategies to minimize complications like tension pneumothorax, dyselectrolytemia, myocardial infarction, tube displacements, or plugging. And an important point here is cardiac arrest suspected due to dynamic hyperinflation. Disconnect the patient from ventilator and a trial of hypoventilation 2 to 3 breaths per minute for few minutes. Third question is review in short literature about the renal replacement therapy in ICU. This is for 10 marks. For the purpose of presentation here, I have mentioned it individually, but this can be mentioned in a tabular form. It would be easier to present and write. The first is a Kiki trial, mentioning everything in short here. So a Kiki trial was a multi-centered RCT, the artificial kidney initiation and kidney injury trial, early RRT initiation at KDIGO stage 3 with delayed initiation based on clinical deterioration. The results said that no significant difference in 60-day mortality between early and delayed initiation groups, suggested delaying RRT until clear indications appear may be safe and reduce unnecessary exposure to RRT. Here we have not mentioned all the trials in detail, just the important points. Elaine trial, which basically compared early versus late initiation of renal replacement therapy in critically ill patients with acute kidney injury. So it was a single center randomized control trial initiated RRT at KDIGO stage 2 for the early group. Results here were early initiation was associated with a significantly lower 90-day mortality. And Elaine trial was the only trial which indicated that early RRT might be beneficial in some patient population. Since it was a single center trial, its design limits generalizability. Ideal ICU trial, again a multi-center trial in septic shock patients, comparing early RRT initiation within 12 hours of AKI diagnosis with delayed initiation based on traditional indications. No significant difference in 90-day mortality was observed between early and delayed initiation groups. In septic shock, early initiation of RRT did not appear to confer survival benefits, and the trial claimed that it may increase RRT utilization without improving the outcomes. START AKI trial, which is a recent 2020 trial, which was a large international RCT comparing early RRT initiation within 12 hours of KDIGO stage 2 or higher with delayed initiation based on clinical deterioration. The results were there was no significant difference in 90-day mortality, but fewer days on renal replacement therapy in the delayed group. It claimed that the routine early RRT may not improve survival and it could lead to higher RRT utilization. The latest Akiki 2 trial in 2021 also was along the same lines, but this trial compared critically ill patients with severe AKI, KDIGO stage 3, with more delayed initiation of RRT to the standard delayed strategy based on the clinical and biochemical criteria. The Akiki 2 trial said that a more delayed initiation did not worsen outcomes, and there was a decrease in the total use of RRT, supporting a more conservative approach to the RRT initiation. And it advocated for careful patient monitoring and delaying RRT until absolutely necessary in critically ill patients with severe AKI. So these are the 5 trials. I have included the next 3 trials of CRRT. Again, if you can remember it, fair enough. Otherwise, we can skip it. So the A-Teg trial is acute renal failure trial network, which indicated that higher intensity of CRRT did not significantly improve recovery rates compared to the standard CRRT dose. And it said that standard CRRT could be both safer and effective. Renal trial, again, like the A-Teg trial, said that there was no survival benefit for the higher doses of CRRT, and supporting the practice of standard CRRT dosing and avoiding unnecessary fluid removal risks. Ivory trial suggested that delayed initiation might avoid unnecessary CRRT in patients likely to recover. And although timely initiation is essential in cases of severe complications such as metabolic acidosis and fluid overload. And finally, this is an important study, the BEST kidney study, which evaluated various aspects of CRRT practices, such as timing, anticoagulation, and modality across different patient demographics globally. The BEST kidney study highlighted that practice variation could affect patient outcomes, individualized CRRT protocols based on patient stability, clinical needs, and available resources. To summarize, the current guidelines basically indicated by KDIGO is personalized approach to RRT initiation based on individual patient condition rather than strict timing thresholds. Early RRT initiation did not confer a consistent mortality benefit. Importance of avoiding unnecessary RRT in patients who may recover kidney function without it, and importance of individualized CRT dosing, careful timing, patient-centered approaches, and improved CRT outcomes in ATN and AKI.
Supriya, just 1 minute. This is the question where it is like an essay, a short essay, where there is no clear clue given to you what to write. It's just a one-line statement of discuss initiation or discuss about renal replacement therapy in the ICU. And if you remember, in the month of September, October, we had discussed around 6 to 7 domains of important studies under the heading of you must know these studies in critical care by various specialties or by various leading speakers in India. We have covered major 6 domains: neurocritical care, acute kidney injury, renal replacement therapy, IV fluid sepsis, hemodynamic, mechanical ventilation. And if you remember, Dr. Lobo had discussed all these 8 trials in his discussion of acute kidney injury, renal replacement therapy. So my suggestion would be you will definitely get such kind of question, at least 1 or 2 questions in your DRNB exam, because this is the super specialty exam, and examiner knows that you have spent 3 years in a specific area and you should be master or would call something like PhD in this area. So you can't say excuse that I don't know the trials and I don't know the literature. The important studies or important trials which are published in last many years in our field of critical care medicine, you must remember them. That's why we specifically discussed the 6 domains of clinical studies which you must know in our previous discussions which I mentioned. So if you are trial haters or study haters, then it's probably red warning or alarm for you that you should go through the important trials which are published in critical care medicine in our specialty, because you're expected to know them at least for your exam and for your practice also, right? Go ahead.
Fourth question is describe methods of indirect calorimetry for 6 marks and write a short note on immunonutrition for 4 marks. So indirect calorimetry is a non-invasive method for assessing energy expenditure by measuring oxygen consumption VO2 and carbon dioxide production VCO2. These values are used to estimate the body's metabolic rate by applying to specific equations. Here I have kept the answer to the point relevant to the critical care use of indirect calorimetry in critical care. So the first one is open circuit indirect calorimetry with a metabolic chart. Most widely used method in the ICU involves connecting the patient to a metabolic chart via a face mark or ventilator circuit. The cart measures oxygen consumption and carbon dioxide production, which are then used to calculate energy expenditure. Advantages are non-invasive, generally accurate, provides continuous or intermittent measurements, which is practical for patients on ventilators. Limitation is the equipment is sensitive to leaks, causing inaccurate readings, requires regular calibration, and it is challenging in unstable patients. Canopy or hood system, it is an open circuit method which uses a canopy or hood placed over a patient's head. The hood collects exhaled gases and the metabolic cart analyzes the VO2 and VCO2 to determine energy expenditure. Useful for non-intubated patients, allowing energy expenditure measurement without physical contact with the face. Limitation is it is not ideal for patients who require frequent access to face for care, and it can be affected by gas leaks. Third is the integrated measurement in ventilated patients. So, for mechanical ventilated patients, indirect calorimetry is often integrated directly into the ventilator system. Certain modern ventilators have built in gas analyzers that measure VO2 and VCO2. Benefits are it reduces the need for additional equipment and offers continuous real time monitoring of metabolic needs, and it is less prone to disruption from leaks. Limitations being patients limited to patients on specific types of ventilators, which might not be available in all ICU settings. Handheld or portable indirect calorimeters provide quick measurements of energy expenditure using breath samples. Some handheld models are adapted for short-term assessments. Limitations are they are less accurate and than metabolic or ventilator integrated systems, and they are unsuitable for continuous monitoring, especially in ICU patients. And Douglas back technique, unless not an important point here in relation to critical care. Just a quick word that patients' exhale gases are captured over a specific period in a bag, analyzed for oxygen and carbon dioxide concentrations, high accuracy in controlled conditions. Limitation being it's not practical for ICU or ventilated patients. Next sub question is immunonutrition for 4 marks involving so basically it involves supplementing specific nutrients aimed at modulating the immune response and reducing the inflammation in critically ill patients. Its components are omega-3 fatty acids, which are said to be anti-inflammatory. They reduce cytokine production and modulate immune response. Arginine, which is a conditional essential amino acid, promotes wound healing, supports immune cell function, and enhances nitric oxide production, which improves blood flow. Glutamine acts as a fuel source for immune cells and maintains gut integrity, potentially reducing bacterial translocation and infection risk. Nucleotides support DNA and RNA synthesis, which is essential for cell repair and immune response. Indications and patient selection. So the first is trauma and elective surgical patients. The Aspen 2023 guidelines mention that in critically ill trauma patients, zero point 0.2 to zero point 0.3 grams per kg per day of glutamine with enteral nutrition for the first 5 days, and complicated wound healing continue for 10 to 15 days. So immunonutrition has shown reductions in infection rates and shortened ICU stays. In burn patients, the Aspen Guidelines 2023 specifically mentioned that enteral glutamine in more than 20% of body surface area burns, uh, zero point 0.3 to 0.5 grams per kg per day for 10 to 15 days. It is supposed to reduce infection and promote healing. Limitations are there are mixed results in medical ICU patients. So, redox trial, it is quite important, indicated that there was no benefit of glutamine and antioxidants, and there was a trend towards increased 28 day, I'm sorry, it's 28 day and 6-month mortality in glutamine supplemented patients. The Omega EN trial suggested that in ARDS patients, it was pre-terminated because it was did not reduce the immunonutrition, did not reduce ventilator-free days, and increased trend towards 60-day in-hospital mortality was observed. The MetaPlus trial said that there was no effect of the cocktail of macronutrients, glutamine, fish oil, as well as micronutrients, selenium, vitamin C, vitamin E, zinc, on the primary endpoints of sepsis. There are also risk of metabolic derangements with immunonutrition, more expensive than standard nutrition, and it is not suitable for all the critically ill patients. Final question, biostatistical question. So explain the biostatistical terminologies with examples and diagrams. Number needed to treat for 4 marks. Kaplan-Meier curve for cumulative survival possibilities, 3 marks. And consort flowchart for 3 marks. So numbers needed to treat. Number needed to treat indicates the number of patients who are needed to be treated with a particular intervention to prevent one additional outcome, for example, death or stroke compared to control. NNT is a measure of treatment effectiveness and provides a straightforward way to understand the benefit of an intervention in clinical trials. The formula here is important. It is calculated using the formula 1 upon absolute risk reduction, where absolute risk reduction is the difference in the proportion of events in the control group minus treatment group, basically P control minus P treatment. Interpreting NNT, so if NNT is 10, it means that treating 10 patients will prevent the outcome in one patient. A lower NNT value, which is closer to 1, indicates a more effective treatment, as fewer people will be needed to observe one patients from 10% to 5%. We calculate the absolute risk reduction, which is 0.05%. Calculate the NNT as 1 divided by 0.05, which is 20. Basically, the interpretation is that 20 patients would be needed to be treated with a new drug to prevent one heart attack. I've included a diagram here just to understand the concept. The interpretation here is a lower NNT indicates a more effective treatment. For example, an NNT of 10 is favorable because it suggests a relatively strong treatment effect. A higher NNT suggests a weaker effect, which may raise concerns about the treatment's cost effectiveness and practicality. Next question is Kaplan-Meier curve. This is quite favorite. It has come many times in the previous exams. So it is a statistical method for estimating survival probabilities over time, commonly used in clinical research to compare time to event outcomes. It accounts for censoring, which occurs when patients are lost to follow-up or when the study ends before an event. So the structure is of a Kaplan-Meier curve has x-axis, which indicates time, represents the duration from start of the study to intervention. Y-axis, which indicates survival probability, cumulative probability of survival at each point of time, and a stepwise decline. Each step in the curve represents an event, for example, death, leading to decrease in survival probability. We have a diagram in the next slide to explain the concept and an example. So for example, we can include any example here. In a trial comparing survival of two groups, for example, treatment A versus control, the Kaplan-Meier curve may show treatment A gradual decline in the curve, which indicates a higher survival over time, and a control, which is a steeper decline, suggesting lower survival, indicating a possible benefit of treatment A. Clinical application of Kaplan-Meier curve. So oncology trials to assess survival benefit, and ICU research to compare survival times of critically ill patients. The final question, consolidated standards of reporting trials flowchart. It is a standardized visual representation used in randomized controlled trials to document the flow of participants through each stage of study. Benefits of using the consort flowchart are transparency, clearly displays the participant flow, gives the study credibility and reproducibility. Bias reduction helps minimize selection and attrition bias by detailing exclusions and follow-up. Standardizations adheres to guidelines recommended by major journals and research institutions, improving research quality. Structure and stages of a consort flowchart. So there are 5 structures and stages. First is enrollment, which involves number of participants assessed for eligibility and those excluded with reasons. Randomization, participants allocated to intervention or time groups. Allocation, details on how participants are assigned to each group. Follow-up, reports on participant retention and reasons for loss of follow-up. And analysis, which is the final count of participants included in the analysis. We have included the consort flowchart here. So this is an example. Any example can be included. So here, as we can see, there is assessed for eligibility, N was 500, excluded N 100, given the reason here, not maintaining criteria, declined to participate. Then randomization, so the numbers were 400 here, randomized to control or intervention, 200, 200 each. Then lost to follow-up, 10, lost to follow-up, 8. And then finally, the number of patients 190, number of patients analyzed 192. That's it. Thank you.
Thank you, Supriya, very much for crisp and good presentation of the answers, and Avrojita also. I think with these 30 questions in last 3 Saturdays, those who are appearing for the exam in January session might have got a reasonable idea how to write an answer in 3 hours. Unfortunately, the pattern of your knowledge thoroughly, but it's the ability to translate your knowledge into bullet points that exactly is tested in this type of theory exam. But this is the system we have set for testing, and we have to cross this hurdle to pass theory exam so as qualify for your practical exam. So you have to practice writing answers. Today is 16th of November. Still, I think 50 days are left for your theory exam, and we wish you all the best for the theory exam. We'll continue our presentations. Next 6 presentations will be also important because next 6 presentations will be discussing about the important studies and articles published in 2024. This will be important for theory as well as for practical discussion also, because when an examiner sets the paper and wants to include a research article or a study to be discussed, many times examiners tendency to go to the recent article which has been published in last year. So it's worthwhile to discuss the articles published in 2024. And my 6 esteemed colleagues from all over the India and abroad will discuss the important articles published in 2024 in the next 6 Saturdays. That is our routine 1:30 webinar. From next time, we'll discuss about neurocritical care. Then in the pipeline on 23rd, we'll be discussing important studies published in the field of neurocritical care. Then on 30th of November, we'll be discussing important studies published in the domain of respiratory failure and mechanical ventilation, then hemodynamics, then AKI, CRRT, IV fluids, then nutrition, and then lastly about infection and sepsis. So next 6 Saturdays will be important discussion on the recent articles published in 2024. So we have given a caption that's year review of 2024, which is important for exam going students because many examiners, as I said, will be asking questions from those trials as well. So thank you very much, Avrojit, my colleague.
Thank you, sir.
Kolkata, and Supriya, my colleague from our own hospital, Mangeshkar Hospital in Pune, for